Good afternoon. My name is Anett and my thesis is the invisible presence of microscopic colitis. I'm a second-year PhD student in the group of gastroenterology and endocrinology of the CTM, and I am also a scientific methodology supervisor in the group of gastroenterology for the first-year students. In my vision, some vigilant physicians educate patients to prevent the development of the disease microscopic colitis. My mission is to provide professional knowledge about the clinically relevant risk factors for microscopic colitis. To achieve this, I have two projects. My first topic, microscopic colitis is a risk factor for low bone density. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors regarding the relationship of microscopic colitis with low bone density. First of all, both diseases are more frequent in elderly women. Moreover, postmenopausal women can get hormonal substitution therapy, which in turn can cause microscopic colitis. Furthermore, budesonide, the gold standard therapy of microscopic colitis, is a corticosteroid with low systemic bioavailability due to its high first-pass metabolism in the liver. Besides, it was reported with contradictory data on its relationship with LBD. So our aim was to scrutinize if microscopic colitis is a risk factor in LBD development. You can see our clinical question, and we applied two frameworks, the PECO and the COCOPOP. We made our systematic search on the 16th of October 2021. Our search key was constructed from two main parts. The first part contained MC and the three subtypes of it, while in the second part we included osteoporosis and the synonyms of it. We made our systematic search in 5 databases and we got around 3,000 hits, but the number of included studies in this review was 4. Our first outcome was if MC is a risk factor for LBD development. We investigated MC patients compared to age and sex matched controls with a 37% moderate heterogeneity, presumably due to the Rancz study, which has a cross-sectional study design with the youngest and the smallest number of patients. Our overall measurement was 2.13, which means that microscopic colitis doubles the odds of low bone density. Then we investigated if MC is a risk factor for osteopenia and osteoporosis. We found an odds ratio of 2.45 in the case of osteopenia, and in the case of osteoporosis, an odds ratio of 1.42 of its occurrence in the presence of microscopic colitis. However, the latter association was not confirmed statistically. Our proportional analysis investigated bone mineral changes in the MC population. 2/3 of the MC patients have low bone density, the overall proportion being 0.68, with a 75% considerable heterogeneity, presumably due to the Greenberg study, which was only a conference abstract with the oldest population. We have MC patients with osteopenia with a proportion of 0.51, and the proportion of osteoporosis was 0.11. The strength of our work is that this is the first comprehensive study regarding the relationship of low bone density with microscopic colitis. All the included studies use DEXA to measure bone mineral density, and we applied a rigorous methodology. On the other hand, we have some limitations, like a low number of included studies with different study designs, low number of study participants, and a female predominance, and eventually we lack data to pool the adjusted odds ratios. Our data suggests screening MC patients for bone mineral density at the moment of diagnosis. Based on our findings, we can recommend lifestyle and dietary changes in case of osteopenia, calcium and vitamin D supplementation, and we also recommend impact exercise combined with resistance training because it was shown that this fits the best for pre- and postmenopausal women to maintain their bone mineral density. Regarding implications for research, further incidence studies are needed, and we would like to highlight the need for international and national registries with bone mineral density follow-ups. We traveled a long way together with my team, and we submitted our manuscript to the Journal of Therapeutic Advances in Gastroenterology, and we received a positive feedback. So here you can see our published article. Microscopic colitis is suspected to be an underdiagnosed disease which might be one reason for having small sample sizes in our first analysis. On the other hand, one limitation was that most of the included studies lacked confounding factors, and these factors might be the risk factors for microscopic colitis. Thus, we wanted to investigate these aspects of the disease. In Europe, the incidence of microscopic colitis is around 11 cases per 100,000 persons. A multitude of data is available on the risk factors for MC. However, these associations are reported with contradictory data and certain limitations. Therefore, we aim to assess the real risk factors for microscopic colitis in adult patients. We applied the PEO framework investigating adult patients having unchangeable like age, gender, and changeable lifestyle risk factors and medications for developing MC, and we hypothesize that the odds of developing microscopic colitis are higher in the presence of the risk factor. We made our systematic search on the 18th of December 2021 in 3 databases and got around 5,000 hits. The number of included studies in the meta-analysis part was 46. Since MC diagnosis is based on colon biopsy examination, all of our analyses were divided into groups of the comparison of MC patients compared to histologically verified and non-verified random controls. Due to the lack of time, I would like to show you the comparisons between MC patients and histologically verified control groups. In our first analysis, we investigated the mean age difference between the MC and the control group, and we found that MC patients are older with a mean of 7.76 years. From now on, all results are presented using odds ratios as a measure of effect. So when we investigated the female sex, if is a risk factor for MC development, we have found a significant result with an odds ratio of 1.80. We wanted to see if higher education is associated with MC development, but similar results were found in the case of below and above high school education. Checking lifestyle factors like alcohol consumption, all available data are coming from the comparisons of MC patients to random controls. We found an association between alcohol consumption and MC development with an odds ratio of 1.67. When we were investigating the relationship of smoking and MC development, we divided MC patients into groups of current smokers and past smokers. Current smoking investigation resulted in a 1.71 odds ratio, and past smokers, the investigation resulted in a 1.19 odds ratio. Checking medications, proton pump inhibitors were not associated with MC development. The odds ratio were higher than 1, however, the confidence interval lower limit was not higher than 1. Regarding nonsteroidal anti-inflammatory drugs, it was found to be associated with MC development, so NSAID therapy doubles the odds for MC development. And last but not least, selective serotonin reuptake inhibitors turned out not to increase the odds for MC development. The strength of our study is that we applied a broad search key, which resulted in a high number of included studies, analyzing a huge patient data and applying a rigorous methodology. Some limitations, like many case control studies, including various definitions of risk factors and scarce adjusted odds ratios. Our data confirm that older age, female sex, alcohol consumption, current and past smoking, and NSAID use are associated with the development of MC. With the aid of our findings, we would like to raise more awareness of the disease, and patient education might prevent the development of the disease. Regarding implications for research, further incidence studies are needed to assess the medication's dose, time, and frequency effects, and also highlighting the need for international and national registries. I am currently in the article writing phase, and we would like to submit our paper to the Elementary Pharmacology and Therapeutics Journal. Doing that during summertime of 2023. Altogether, I have presented my projects at several conferences, and I would like to close my presentation with the words of Beverly Sills: "There are no shortcuts to any place worth going." Thank you, and I'm open for this discussion.
Okay, it was very interesting. And I'm wondering what's the reason that the microscopic colitis could evoke osteopenia? Because it's involved only the colon, so it's not so much interfere with the absorption. How would you explain?
Thank you for your question. Microscopic colitis is characterized by chronic watery diarrhea, stool leakage, and nightly defecations. And we suspect that it might be one reason for losing calcium throughout this chronic diarrhea, and that might be one reason for having osteopenia.
Okay, and
another explanation could be that microscopic colitis is a little bit more common in elderly women.
yes.
So this is the alternative explanation.
It's okay, but in this elderly woman, otherwise also it's a bit higher. Did you examine in a subgroup analysis for men with microscopic colitis? Is there a difference between them, or even is it higher in men with microscopic colitis?
And thank you for pointing this out. However, as I mentioned, that we only included 4 studies and high sample sizes with more than 80% of female predominance. So there was no data regarding the division of females and males having osteopenia.
And maybe it could cause this dose-provoking factor. You mentioned alcohol consumption, smoking. Is there any data that these factors could influence the osteoporosis? Would be increased?
These were, thank you for the question. Alcohol consumption and smoking were associated with MC. I have read in the guideline of osteoporosis that like a certain risk factors for having osteoporosis and fracture risk are also like smoking and alcohol consumption, which might increase this chance to get it. However, I would say that we did not have enough data because the included studies lacked confounding factors, and there were no adjustment for alcohol consumption and smoking, unfortunately.
Thank you very much. Very nice the subjects, very nice the presentation, very interesting. Most of the time, lymphocytic colitis and collagenous colitis are treated together. Is it correct? Do you think that we have to move on? Maybe did you find something on that? All the time they are together?
Currently, the guideline suggests budesonide, which is the gold standard.
Yeah.
Maybe that should be investigated furthermore. Maybe that might be one next topic for our investigation.
Okay, thank you.
Have you recommend the screening for vitamin D deficiency for such kind of patients? Do you recommend the screening for vitamin D deficiency?
Vitamin
routinely,
D?
Yes.
If I would recommend it, in our studies, there was only one study which assessed this vitamin D level. So based on that, I might recommend it, yes. In case of there is any change for the bone mineral density, we would definitely recommend to take vitamin D.
And have you examined the role of previous operations like cholecystectomy, appendectomy as a risk factor for microscopic colitis?
Thank you for the question. If I remember correctly, there was also investigation here at your center, or there was at least reporting data from there, and investigating cholecystectomy and appendectomy. We have investigated. Due to the lack of time, I didn't show them, but they turned out not to be associated with microscopic development, colitis development.
Thank you. Actually, my question was about the vitamin D deficiency and the levels of vitamin D by the initial setting of diagnosis. Maybe a question, these studies were from which regions that were included into the meta-analysis? Was there like the Nordic countries, or it was like the Mediterranean, or?
Thank you for the question. I cannot go back. The study of Viet et al. Was from Denmark. The study of Graziano was from Spain. And the study of Rancz is from Hungary. And the study of Greenberg, which is only a conference abstract, came from America.
Okay, so
very heterogeneous.
Yeah. Because what we see in IBD patient studies, especially on the osteoporosis and the vitamin D, there is a huge discrepancy between the Nordic countries, for example, Ireland, Norway, and Mediterranean countries. So that's why it should be taken
Yeah.
So why did you say that the certainty of evidence is very low?
Thank you for the question. We applied the Grade Pro guideline, and we had to downgrade because of the low sample sizes. And because of the studies used the surrogate outcome, the Grade Pro guideline define that bone mineral density is only a surrogate outcome, and the primary outcome would be the fracture risk. However, we have only found one article which was measuring the fracture risk.
What did that article say about fracture risk?
That article said that the MC is not a risk factor for low bone density altogether. However, they find a restrictive decrease in the hip bone to be associated with it.
Mm-hmm. Okay. Can we switch to the next one, please?
Sure.
Okay. If you wanted to explain to a colleague, to a clinician who is less statistically inclined, what would you tell about an odds ratio is?
I would say that it shows the ratio of odds, like measuring from 0 to infinite scale, and we could tell that if the odds ratio is equal than 1, it means that there is no difference between the two groups. In the case of the first investigation, if the odds ratio is higher than 1, it means that the investigated exposure is a risk factor, such in that case for osteopenia, the MC. And in the case of osteoporosis, the odds ratios are increased. However, since the confidence interval are not higher than 1, it means that that is not statistically significant.
Thank you. Thank you very much. Any other question?
Congratulations for these topics. Actually, I was wondering which medications did you investigate? Only these that you presented, I mean, as a risk factor? Because I understand why you showed us the nonsteroidal, whatever, yeah, and so yes, but you also presented SSRIs, which were not associated, and I was wondering why you wanted to highlight, or what could be the mechanism by which it could be a risk factor. I'm not aware how could be disconnected, or yeah.
Thank you for the question. The reason behind I have highlighted these medications because Like, for example, PPI, of course, it is well used in gastroenterology. However, these medication-associated MC were reported in the guideline. However, we have found that in the guideline, most of the included studies were the comparison between MC patients compared to histologically non-verified random controls. And since MC diagnosis is based on histological diagnosis, we would say that it is a more reliable data. So that is one reason for presenting these kind of medications. Regarding other types of drugs, we have investigated all the drugs that have been mentioned there. We have as well SA inhibitors, beta blockers, aspirin, and so on. There were some associations, but mostly with random controls. Due to that might be several reasons inside the articles. Currently, they are not here to show them. But
we are just talking about, because this patient have long-term diarrhea. So what about the restrictive diet that the patient might have before? We're just speculating.
Thank you for the question. Since patients are, there might take years for diagnose the patient, because it takes a good GP, it takes a good gastroenterologist, it takes a good histopathologist to put it together, the diagnosis. So these patients might get afraid from eating, and they should not get afraid of it, because it does not help on getting rid of the chronic diarrhea. Of course, eating, then you get more diarrhea. However, we do not suggest getting a restrictive diarrhea, highlighting the fact that it should take more diary food like broccoli, canned salmon, and milk intake to put it together the calcium level for bone mineral density.